skin, peripheral nerves, mucosa of the respiratory tract and the eyes. Musculoskeletal involvement is common but underreported. Remember that arthritis and tenosynovitis may be the only presenting manifestation of leprosy, and travel and migration have rendered leprosy a global disease. And you can see report of leprosy after infliximab infusion from USA, and an overlap between Hansen's disease and rheumatoid arthritis, again reported from the United States. It's a very old disease, and the interesting fact, I thought, was that M. leprae was detected before Mycobacterium tuberculosis, but because it couldn't be cultured, it really couldn't stand the test of Koch's postulates. It is endemic in greater than 22 countries and has a huge prevalence. The incubation period is anywhere between 4 months to up to 30 years. The male and female ratio is 1.5 to 2:1. The transmission is predominantly aerosol nasal secretions and to close contacts. The relative risks is anywhere between 2 and 10. And the prevalence of arthritis and leprosy is variable, reported between 1 to 78%. And this variability comes in from people unable to really recognize that that's happening. The pathogenesis is somewhat unclear, but includes reactional states, type 1 and 2, direct infiltration of the synovium, and neuropathic joints as a consequence of nerve involvement. Type 1 or reversal reactions have a Th1 cytokine response with an increase in TNF-alpha. Type 2 reactions or ENL reactions occur in borderline lepromatous and lepromatous leprosy. There is immune complex deposition with activation of complements and high levels of TNF-alpha. Remember that ENL may be the presenting manifestation of leprosy. We have skin involvement, classically hypopigmented and anesthetic. We have peripheral and cranial nerve involvement. Remember, the two important things to go first are sweating and the loss of temperature. You can have systemic features. Pure neurotic leprosy without skin involvement occurs in 5 to 10% of cases in India, and musculoskeletal manifestations hence are often ignored by dermatologists and physicians alike. Now let's have a look at the classical rheumatological presentations. So if we have a lepra reaction, we will have an acute symmetrical polyarthritis, and that's the line I am following, which could involve the small and large joints. Erosions may or may not be present. You can detect leprae bacilli in the synovium, and response to MDT is good. Then there is a swollen hand and feet syndrome, which can occur in a reactional state or otherwise will have an acute symmetrical polyarthritis involving small and large joints, does not have erosions. You may find leprae bacilli, and the response to MDT is good. Then again there is a chronic arthritis, and we'll talk about that in a greater detail, which is insidious, symmetrical, small and large joint with erosions. You may or may not find leprae bacilli, and there's a moderate response in the sense that even though it does decrease, but sometimes it persists and goes on to develop like rheumatoid arthritis. Then of course you have Charcot's arthropathy, which is a neuropathic joint. And finally you have tenosynovitis, which could be acute or insidious, extensor tendons of hands or feet. And you do find M. leprae in synovium or the tendon sheets, and the response to MDT is good. So these are the classical presentations. And therefore you could have edema of the hands or of the feet, and these could be the presenting manifestations of leprosy. And you could confuse them to a variety of rheumatological disorders, including gout, if there's edema on the feet. And then extensor tenosynovitis with involvement of the wrist and the MCP joints, and you can see the amount of tenosynovitis in the hands here. Let's look at a few cases. We had a 42-year-old female who presented with inflammatory small and large joint polyarthritis for about 2 years. There was probably carpal tunnel in the right hand with tingling. The rheumatoid factor was positive, and the anti-CCP was low titer positive, cutoff being less than 18. So So we made a clinical impression of rheumatoid arthritis. Those are the hands. And you can very classically see that you look at them and say, well, this is rheumatoid. I think at that time what we did miss was that there was wasting on the ulnar aspect of both hands. We missed it at that time. Anyway, so we diagnosed her as rheumatoid arthritis, gave low-dose steroids and DMARDs. There was resolution of arthritis on the next visit, but the patient developed burn lesions on fingers because she was not able to feel the hot sensations on her hands for the last 6 months. We did a sural nerve biopsy suggestive of Hansen's disease and of course started MDT. DMARDs were stopped and the patient improved. We had a 31-year-old male who presented with fever and diarrhea for 3 days about 6 weeks ago. Arthritis involving the left wrist, bilateral knees and ankle for the last 4 weeks. Examination revealed effusion, tenderness and arthritis, but there was no definitive skin rash anywhere on the body. You can see bilateral knee involvement. We had inflammatory parameters. The fluid aspirated was inflammatory. Rheumatoid factor B27 negative, there was no erosions and the SI joints were normal. So kind of, is it reactive or not? Or an undifferentiated spondyloarthropathy or maybe a seronegative RA. However, the pathologist did report that the synovial fluid AFB was positive. The patient was reassessed suspecting tuberculosis, oligoarticular. But there was a thickened and cord-like ulnar nerve, and this is the ultrasound of the ulnar nerve, which is almost tendon-like. So we had almost a 12 to 13 millimeter ulnar nerve. We did a sural nerve biopsy, which was positive for lepra bacilli, and the synovial fluid TB-PCR was negative. So leprosy did present in this case with reactive arthritis-like presentation. And remember that joint fluid AFB can rarely be positive in leprosy. Now we had this 45-year-old male who had pain and swelling of nose and ear, 2 or 3 episodes over the last 2 years, intermittent fever and intermittent tenderness over trachea and larynx. And we had an ear like this. Normally as a rheumatologist I would start thinking relapsing polychondritis. The way the ear looks, is it psoriasis, secondary infection or whatever. But remember here that in relapsing polychondritis, it's the cartilage that's involved, while in this case you see that even the ear lobule was involved and that was the telltale sign. So the ear lobule slit skin smear was positive and the patient was actually having chondritis of the ear, nose and larynx because of lepromatous leprosy, and it's very well described in leprosy cases. And then if you have an erythema nodosum with an ankle arthritis, you start thinking, is it a vasculitis, is it ANCA, is it sarcoid? But turns out to be leprosy. Or if you have a vasculitic-like picture, so this is pre-treatment and post-treatment. The only treatment that was given was steroids initially and MDT, and this was a Lucio phenomena, which again is well described in other countries in the world. And you can see here almost a vasculitis-like picture. You had some nodules here on the skin. And in this case, in the vasculitis-like presentation, you had weight-fight stain positive bacilli in the endothelium of the capillaries of the dermis. And that is what was causing a vasculitic-like picture. I always find this case interesting. I had a look at this patient's hand and asked him, do you have skin disease? And he said, no. And so I said, so what's happened? So he said, I've bitten off the nails. So don't they hurt you? How did you manage to chew off half your nails? And the reason was he had a hypoanesthetic patch on the abdomen and his ulnar nerve, 4th and 5th fingers were anesthetic. He just chewed his nail off. So again, it was Hansen's disease with arthritis. And sometimes the ear can be extremely subtle, but then if you carefully look at this nerve running across the sternocleidomastoid muscle, you will realize it's a thickened great auricular nerve, and that may be your clincher for a diagnosis of Hansen's disease. Other people have also looked at arthritis and leprosy, so you have acute arthritis and chronic arthritis, and it's been well reported just as we have described previously. So the presentations that we've seen, we could have a lepra reaction with arthritis and ENL, we could have swollen hands and feet syndrome, we could have chronic arthritis, we could have Charcot's, we could have tenosynovitis alone, a vasculitic or Lucio-like phenomena, reactive arthritis like, sarcoid like, relapsing polychondritis like, we can have a cryoglobulinemic vasculitis, enthesitis uncommonly, and rarely sacroiliitis. It can mimic practically everything. You have to have a high index of suspicion to diagnose. There have to be hypoanesthetic patches or thickened nerves. Do a slit skin smear, do skin biopsy, do a weight fight stain, which is a modified Zeal-Nelson stain, a sural nerve biopsy. Synovial fluid is rarely revealing. Of course, you can catch the occasional AFB. And then there are others like nerve conduction, velocity, ultrasound, and others. Rheumatoid factor may be falsely positive in leprosy arthritis. Anti-CCP is somewhat specific for rheumatoid arthritis, but remember it can be positive too, so don't be misled. In a